It's my pleasure to share this session with my dear colleague, Dr. Hani Khattab, and it's really an honor to be here with all of you during the world of pathology. We have 4 talks today, presented by Dr. Aisha Sahin and Dr. Frederic Pinon and myself. We are going to cover many subjects, including the DCIS, the genetics and immunohistochemistry in breast cancer, HER2 updates, testing, and finally interactive case presentation, again introduced by Dr. Aisha Sahin. And it's my pleasure now to introduce to you her first talk on DCIS, diverse histopathologic and molecular biology. Dr. Aisha.
Thank you very much. Good afternoon, ladies and gentlemen. It's really wonderful to see this entire room full. I really would like to congratulate the organizers. You really did a great job. And thank you very much for all of you for being here today. So I would like to talk about ductal carcinoma in situ today. And the areas that I am going to cover are included here. A little in on the natural history of DCIS, very briefly morphologic features and differential diagnosis. Again, this is not going to be a talk where I'm going to show you a lot of DCIS pictures, more I'm going to talk about some of the biologic factors, and I would like to summarize some of the ongoing clinical trials. Even though majority of this is not going to be a pathology talk, I think it's extremely important for us as pathologists to be aware of where entire field of DCIS is going and what is going on in terms of clinical trials and how we can participate in these clinical trials. The incidence of DCIS is increasing. There is no question. It is increasing everywhere. In our cancer center, it is 20% of our practice right now. And it is increasing because of mammography. Since the screening programs have started worldwide, the incidence has increased. And this increase is due to predominantly application of digital mammography. The breast imaging modalities really have not changed significantly for several decades, but in the last couple of decades there are major advances. And one of the advances actually we will be seeing now, there is this photon counting technique that our mammography colleagues are applying, and this really increases the sensitivity of screening, and we will be seeing more and more early lesions and DCIS lesions. One thing is clear, that when we make the diagnosis of DCIS, we are not talking about a single disease. This is a very heterogeneous disease, just like invasive carcinoma, from clinical presentation, the clinical features, and biology and behavior. Is DCIS definitely a precursor lesion for invasive carcinoma? And the answer is yes. And where do we know this answer? There are multiple studies over the years have published looking at the risk of development of invasive carcinoma after a lesion is diagnosed as DCIS on a biopsy and nothing else was performed. So when we take all the studies together, 28% of these lesions progress to invasive carcinoma. So it's definitely a precursor lesion. How about the low-grade DCIS? What is the natural history of low-grade DCIS? Again, the data for this is coming from studies where the lesion was misdiagnosed and nothing has been performed, and on the follow-up, what do we see? 39% of these lesions progress to invasive carcinoma, and interestingly, 18% of the patients die of breast carcinoma. So it's definitely a precursor lesion. And the Nurses' Health study of the CIS also confirmed this finding, that close to 2,000 breast biopsy samples were retrospectively reviewed, and 13 cases were diagnosed as low-grade DCIS, and these were all grades, not only low. And all these patients progressed to invasive carcinoma, and then the odds ratio for developing invasive carcinoma is 13.5 compared to non-proliferative lesions. And if we include the CIS in invasive carcinoma, it is 20.1. So definitely these lesions is precursor lesions. Not all cases progress, but at least 25 to 30% of the patients progress to DCIS. And more importantly, when these patients develop carcinoma, they are all in the same breast in the vicinity of previous biopsy. In some cases, these are retrospective reviews, so it's very difficult to really locate the lesion, but they are all in the same breast. So in terms of conclusions of is DCIS precursor lesion or not, we can definitely say that it is a precursor. It is not an obligatory precursor, but it definitely is a precursor lesion. And for a long time, in terms of breast carcinoma progression model, we always use a normal to proliferative disease to DCIS or invasive carcinoma. With all the molecular advances now, we know that this is a one pathway, but there are alternative models for invasive carcinoma to develop. Many lesions can develop from normal to invasive carcinoma without a morphologically identifiable lesion. Of course, there are a lot of molecular aberrations from normal to invasive carcinoma, but we really do not have a morphologic intermediary lesion such as proliferative lesions or DCIS. And some of them go to a proliferative lesion, and DCIS is the endpoint, doesn't progress to invasive carcinoma. And how all these different molecular pathways relate, how can we prevent these lesions is a major area of interest, and we really do not have a lot of the answers right now. In terms of morphologic differential diagnosis, obviously atypical proliferations, lobular carcinoma in situ, and invasive carcinoma are our main differential diagnosis, and 90% of the cases, this differential diagnosis is pretty straightforward, that we can really have set criteria to arrive at a diagnosis. The current understanding of ADH, the way we define ADH is that the cytologically similar lesion to low-grade DCIS, when we do molecular analysis, that they really show similar abnormalities to low-grade DCIS, because that is how we define the lesion. So it's a very small DCIS-like lesion involving only part of the ductal system, and the morphology is indistinguishable, and we use a quantitative criteria, whatever the criteria that we would like to use. But there are still challenges in terms of this classification, because the clinical relevance of identification of this lesion have been questioned. And that is actually the main clinical question has been raised for making screening tools such as mammography more sensitive. So why do we really have to identify these lesions if they are not going to have significant clinical relevance? And then, after we make the diagnosis, what is the effective strategies for management? So calling something very small DCIS versus palpable DCIS, we know that these are not the same lesions. And more importantly, development of reproducible criteria for classification is also very important. And when we look at the hyperplastic, neoplastic, I mean, these charts make all sense in terms of classification. but a lot of the things overlap. And a distinction of malignant versus benign, it is not really these very defined boxes. And small, well-formed DCIS cases are now, we know that molecularly are very close to lobular carcinoma in situ. Similarly, high-grade DCIS versus low-grade DCIS are two distinct lesions. But in general, if you look at the literature, there are multiple markers that we can use to separate this hyperplastic lesions versus neoplastic lesion. And then one of them is cytokeratins, and the other one is that people have used is estrogen receptor. If you have a proliferative lesion which is heterogeneously stained, it is usually hyperplasia, and if it is more homogeneous, it is neoplasia. Again, these are very general rules. I personally would not make diagnosis based on immunohistochemistry. So this is an example of benign epithelium, and especially with columnar type lesions, the estrogen receptor positivity is positive, but usually it is quite heterogeneous as opposed to low to intermediate grade DCIS. It is usually very homogeneously positive. And when we look at the genetic alterations, either as a loss of heterozygosity or if you look at other molecular testing, what becomes very evident that some of the abnormalities can be evident even at the ductal hyperplasia without atypia. Morphologically, these lesions are, we know that they are not neoplastic, they are not clonal lesions, but they can have molecular level some abnormalities. As the lesion progresses, abnormalities increase, and many of the high-grade DCIS lesions have very similar molecular abnormalities to invasive carcinoma, which in our next session we will be discussing that extensively. So it is very apparent that the low-grade DCIS and high-grade DCIS are really different diseases. Just like in invasive carcinoma, estrogen receptor positive tumor versus estrogen receptor negative tumor are two different diseases, and the same thing happens for DCIS. Low-grade versus high-grade is very different. And the other important thing is that in the past we always think that DCIS is the precursor lesion and LCIS is the high-risk lesion, but nowadays we know that even the low-grade DCIS and low-grade DCIS and then classical LCIS share many molecular changes. And pleomorphic lobular carcinoma in situ and high-grade DCIS share many molecular abnormalities. This is a duct showing ductal and lobular in situ carcinoma in the same duct, and we very liberally use E-caterin to differentiate these two lesions. And although both LCIS and DCIS have morphologic criteria that we make our diagnosis on H&E, we use E-caterin staining. And E-caterin is located on chromosome 16q, which defines the low-grade carcinoma pathway in breast carcinogenesis. So the low-grade lesions, whatever the precursor is, either the columnar cell lesions or low-grade atypical ductal hyperplasias, these are all on this pathway of chromosome 16q. In contrary, the high-grade pathway has very complex chromosomal abnormalities, but most commonly 17q pathway. And when we make the diagnosis of low-grade DCIS versus high-grade DCIS, and this lesion is definitely a lot closer to this pathway than this pathway. So now we recognize that Actually, low-grade versus high-grade are two distinct lesions with this two distinct pathogenesis. As we move to molecular classification of invasive carcinoma, it has been shown that the similar classification system can also be applied to DCIS cases. So there is definitely luminal type DCIS, both luminal A and luminal B, and then there is triple negative DCIS cases. And it has been extensively looked at by gene expression patterns and then serial analysis of gene expression technique to look at the DCIS versus invasive carcinoma to come up with a test that can differentiate if a DCIS is going to progress to invasive carcinoma or not. Unfortunately, there is no universal in situ or invasive carcinoma signature. When we do comparative analysis of DCIS and invasive carcinoma in a single patient, their expression patterns, whatever technique that you are going to use, are very similar. So you can really segregate the patient, which DCIS belongs to which patient who has an invasive carcinoma. They are very similar, but there is no definitive signature that can predict invasiveness or which tumor is invasive carcinoma or which tumor is in situ carcinoma. There is a significant overlap. So this morphologic and biologic diversity has very important implications in terms of mammographic evaluation and distribution, and the most importantly, the patient management. So you cannot really come up with a blanket statement of DCIS should be treated this way, or DCIS should be done this way, or the patient should be managed in the follow-up in a given way. It is very important to know what kind of DCIS and all the other parameters that I am going to discuss are very important. There are definitive clinical factors, so young age, genetic background, these are very important. A patient with a half a centimeter DCIS and a 35-year-old versus an 85-year-old are quite different. Similarly, tumor factors. This is where, as pathologists, we play a significant role. Size and extent of the lesion should be evaluated very carefully, which I'm going to spend some time. Nuclear grade necrosis is important, and when we are evaluating our margin, it's very important to indicate either in your report or in your comment of your report how much DCIS is at margin. Earlier we discussed a little about this, but I'm going to spend more time on that. And obviously, treatment factors are very important. How extensive the excision was, XRT was used or not, or hormonal treatment has been given or not. Size determination of DCIS is crucial. As I indicated before, the split between ADH versus DCIS, like we are talking about millimeters. But when we talk about DCIS, a lot of the time we don't even pay attention to that. But that is also very important. It is frequently underestimated both clinically and on pathology evaluations, and accurate assessment requires careful evaluation of the specimens. In order to illustrate that, I am going to present a case. So this is a 50-year-old lady presented with a suspicious microcalcification on a screening mammogram. She underwent a core biopsy, diagnosis of DCIS was established, and she had a segmental mastectomy. This is the actual pathology report. It says 5 by 4 by 3 centimeter excision, and the specimen is sectioned and submitted in 20 cassettes. So 5 centimeter lesion, 20 cassettes. And the final diagnosis says it's a DCIS 0.8 centimeter, which is a small DCIS. Margins free, the closest margin is 1 centimeter, which is quite well. And then there was previous biopsy changes. So now I'm going to ask you, is this an adequate biopsy, adequate evaluation of segmental resection? Raise your hand if you think it is. So most think it is not adequate. Why? Because it's a 5 centimeter and 20 cassette. Is it few sections? No, it's not. It's an adequate sectioning, right? So why you don't think it is adequate? Okay. Okay. So the most important thing here is, yes, the grade should be included and all that thing, but that we really don't know how these 20 cassettes, these 20 cassettes will be adequate or it might not be adequate. So let's say that this was the lesion, the excision, 5 centimeter, and these are the 20 sections were selected. And if the calcifications were like this, because this was a non-palpable lesion with calcification, if the calcifications like this, and this is a 0.8 centimeter area, and the nearest margin is 1 centimeter, this patient is going to be cured with this lesion. But how about if the calcifications are like that? That the rest of the section was not evaluated. And if you put those areas of calcification, then the diagnosis should have been DCIS, which measures, instead of now 0.8 centimeter, it is 5 centimeter because it involves the entire thing, and the multiple margins are positive. So this patient needs definitely re-excision. If the re-excision requires mastectomy, it's a mastectomy. So what is wrong with this pathology report? The pathology reports that put the samples without the imaging features. So it is very important that you have to correlate with imaging. So if you're not going to remember anything from this talk, please remember this case. So how you put your sections of DCIS is going to make a major impact what that patient is going to receive next. So if you have an excision like this, it should be first oriented, and then we always obtain specimen X-ray for those lesions which are not palpable. This is very important step. Here is the specimen X-ray, and then we serial dissection the specimen, and then we look at the specimen X-ray. A lot of the time, as you train your eye, you can pick up a lot of the things. In our center, we have radiologists who look at our specimens and circle the areas. But as a pathologist, we can do that too. It's no problem. And most of the time, since these are thin slices, to identify the areas and identify the areas of microcalcification, and here is the biopsy site with the clip, is really easy. So when we do our slices, then we obtain our sections. As we obtain our sections, we number them. Again, you do not have to submit the whole thing. In this illustration, I put a lot of sections in, but you do not have to put everything in. But the most important thing that you need to know where your sections are coming from. You cannot just say representative sections have been submitted. So when we have the specimen X-ray, we indicate on that X-ray how we take our sections, and then we look at our slides and then indicate which slides have the lesion, either inside the carcinoma, if there is something else, we indicate that, and then we calculate the thickness of each slices. Like, for example, in this case, from superior to inferior, if the lesion was 5 centimeters, and then if the 3 sections were involved, 3 times of 0.5 is going to be 1.5 centimeter. So we look at these specimen X-rays, and then we look at the slides, and we try to map these lesions very carefully. So when is it appropriate to obtain the specimen X-ray? In my opinion, whenever the preoperative mammographic findings suggest the extent of the disease may not be appreciated by gross evaluation, meaning that there is no palpable lesion, which is the majority of DCIS cases. So it is more important for DCIS to X-ray the specimens than invasive carcinoma. So specimen should be oriented, X-rayed, inked, serially sectioned, and the sections submitted for histologic evaluation. And when we look at our sections, we classify the DCIS, the traditional classification versus more modern classification system, Comedo versus non-Comedo. WHO recommends classifying into low, intermediate, and high grade based on nuclear grading. And for that, WHO did not really specify which grading system should be used, but as pathologists, most of us have this general feeling of what is high grade, what is low grade, and intermediate grade. And then for DCIS, we have to include with or without comedo necrosis. So low-grade DCIS, intermediate-grade DCIS, and one very important thing, and WHO Blue Book also indicates that the nuclear grading and presence or absence of necrosis should be two independent parameters. Rarely, low-grade DCIS can be associated with comedo-type necrosis. In general, comedo necrosis indicates high-grade DCIS, but the nuclear grading should be independent of presence of necrosis. Whatever the clinical, grading system that we use, it has to be clinically relevant. It should be reproducible by different observers. Just like any other grading system in pathology, usually there is a great agreement on the low end and a high end, and then in between there is a definitely subjectivity. And I don't look at this as a major problem because we know that the biologic behavior is a spectrum. So we are trying to put these arbitrary cutoff points to differentiate something which is a little more biologic spectrum. To come up with what is the number of mitosis that you need to see to make it grade 2 to 3. I don't know. You know, like I look at multiple factors and then I call something grade 3. And then same lesion can be looked at by somebody else and say it is grade 2. Is it a major problem? I don't think so. Because when we are making treatment decisions, these are one of the factors. Obviously, we do not want to confuse a low-grade lesion and a high-grade lesion, but when do we make that intermediate, it might be quite subjective. And many people have proposed using additional tests, such as like looking at the proliferation markers and other tools. In my opinion, right now, there is nothing, and any of those parameters, any imaging parameters, as good as morphology. So 2012 Consensus Conference on Classification of DCIS. No single grading system has been endorsed, but it was endorsed that it should be graded. Well, using what? We don't know, whatever the grade, but as I said, high grade, low grade is easy. So we mentioned the nuclear grade, architectural pattern, and presence and absence of necrosis. And when you look at the morphologic features and try to correlate it with some of the molecular findings, there is definitely a nice transition and stepwise increase as the grade increases. Many of these factors, ploidy, the chromosomal abnormalities, amplifications, and molecular subtype, it really increases as the grade increases. But none of these features have